Good afternoon, and welcome to the Alliance for Home Health Quality and Innovations briefing on framing the future of home health care in America. My name is Teresa Lee, and I'm Executive Director of the Alliance, and I'm just so pleased to have all of you here with us today. Today's briefing will provide a preview of the findings, recommendations, and framework from the Alliance's Future of Home Health project. A paper on this topic is pending publication, and we'll look forward to sharing that full published article with you later this year. But today, what we'll be doing is discussing the findings, framework, and recommendations as a preview. Just a little bit of housekeeping before we get started with introductions. First, our three speakers will have about 7 minutes each to speak, and then I will be moderating some panel discussion for about 20 minutes. We're going to leave the last 10 to 15 minutes for a question and answer session. I'm happy to report that today's briefing is being webcast and recorded. What I'd like to do is make sure that we're able to take questions from those of you who are tuning in via webcast. So if you're watching via webcast, you can tweet your questions using the hashtag FutureOfHH. Or you can email them to the email address futureofhh@ahhqi.org. And we'd also love to hear about your thoughts and comments via Twitter. So please do tweet and use the hashtag FutureOfHH. So without further ado, I'm pleased to introduce our three speakers today. Our first speaker is Kathleen Gilmartin, who is President and CEO of Interim Healthcare and also the Chairman of the Alliance's Board of Directors. Interim Healthcare is a national network of franchised home health providers with over 320 locations in 43 states. Our second speaker today is Sally Rodriguez, who's a director with Avalere Health, where she provides analytic and strategic support to healthcare providers using data analysis, research, and policy expertise. With prior experience as an analyst at the Government Accountability Office, she has expertise in key issues involving acute care, post-acute care, and long-term care. And our third speaker is Dr. Steve Landers, who's president and CEO of the Visiting Nurse Association Health Group, the nation's second largest not-for-profit home health care organization. A family physician and geriatrician by background, Dr. Landers authored several articles on the role of home health care in national publications, including the New England Journal of Medicine and the Journal of the American Medical Association. He also recently joined the Huffington Post as a regular blogger. Prior to joining VNA Health Group, he directed home care, community rehabilitation, and post-acute care for the Cleveland Clinic. And with that, I'd like to turn it over to Kathleen.
Thanks, Teresa. It's a pleasure to be here today, and thank you for taking the time out of your day to join us. As an introduction, Teresa mentioned I am the CEO and President of Interim Healthcare. I'm also a registered nurse and have spent most of my career in healthcare, both in acute care, but for over the last 20 in the home health and hospice side. So the industry is certainly going through lots of change, and I think we'll have a chance to touch on some of that with the report. But to give you a little background about the Alliance, I really wanted to just touch on the fact that we are an organization that was really founded in 2008. And that's because really it was the desire of the organizations to really start to fund research and to be able to have the work go on for education and research within the sector of the post-acute area. And we're delighted that we've been able to accomplish a lot of the education and research projects over the last several years. And the mission of this organization is really to basically have the opportunity to show value for home health. I'll let this gentleman take care of technical. But I think that where we're seeing so much change in the U.S., we are able to then take an opportunity to say, where is that value best measured and what should the future of home health look like? The fact that we are going to be today talking about our members, and some of whom are here, the membership is represented with both tax status is agnostic, so it is both for-profit and not-for-profit organizations across the country. And the projects that the Future of Home Health really are focused on are meaningful to everyone in the industry so that we all support the mission and the goals of being able to have a research-based organization. The snapshot you're seeing there, our members, many of you will know, is a cross-section of providers, everything from skilled to the home health support and personal care, and also even hospice. So the Alliance membership and support is what enables this research to actually be published, because everyone is an engaged participant in the Alliance. Today, there are special sponsors that you'll see here: the Access Group, CHAP represented, Unity Point at Home, the Corridor Group, and the Simeone Consulting Firm. And we would like to thank them because they were also very supportive in having this project come to fruition. A special thanks goes to the Simeone Group for your lunch today, so we make sure you don't have a low blood sugar right around this time. And we're excited that we can be here to represent all of the members today on the panel. The project you're going to hear about today is really a culmination that has taken not just one window of time, but essentially started back 2 years ago. So in October of 2014, there was an opportunity to have the Institute of Medicine and the Council on Aging together bring together the opportunity for stakeholders, both providers, all sectors, and it was something that was kind of a unique platform. But what that did is that actually gathered together some of the a lot of the things that were on the horizon were actually starting to be defined. A lot of the evolving changes were now becoming part of our vernacular, and we were seeing it in many parts of the country. So that organizational meeting actually started a series of symposia that went on in 2015 that were sponsored by the Alliance. And that series actually brought together providers, stakeholders, even in some cases patients and families who had experienced home health care. And that really led us to us being here today. So this is really the culmination of being able to have the research published. And we'll be talking about aspects and findings and recommendations, things that will actually help our policy makers, we think, go forward. And just in closing, as an industry, it is important and meaningful for all of us to be able to understand where the value of care at home really is measured, how those systems will evolve over the coming years, because you all know better than I do, and have certainly heard it enough, the demographics are demanding it, the technology is going to enable it, but at the end of the day, we have to be able to provide for care with the longevity that we have in this country, and to do it with dignity and compassion, and really put our best minds at it. So we're excited to be here today as a panel, and I think I thank you for the time again. We will be taking questions later, so look forward to those. And with that, I'll turn it over to Sally.
Thanks so much, Kathleen. Okay, I've got 7 minutes, and there are a lot of slides, and really they reflect a lot of great content that came out of this work. So Teresa, if I'm going a little bit beyond, feel free to give me the wrap it up signal. We wanted to briefly mention the impetus for this work, which I think Kathleen spoke to nicely, but there's really a recognition of the need to be really clear about the role of home health, given the great amount of evolution that's going on in the healthcare system at large. So the Alliance partnered with my firm, Avalier Health, to enter into this project. We did a number of literature reviews. We did interviews with policy leaders and other stakeholders. We looked at the IOM workshop on the future of home health care, which was really informative. And then we also spoke to some really innovative providers doing some really interesting things on the ground. I just wanted to make a note about sort of terminology here. Our project is really focused on the Medicare home health benefit, but we certainly acknowledge there's a much broader spectrum of home-based care, and one that I think can be really leveraged in the future. So there are many drivers that are shifting the focus and patients into the home-based care spectrum. And we all know that there's a demographic shift happening. The number that I think is interesting that In the next 15 years, Medicare enrollment is going to grow more than 50% to 80 million beneficiaries. So just to kind of put it into some numbers for you. We also know that generally patients really prefer to age in place, to have sort of that on-demand care that's moving towards, this patient-centeredness. You're probably hearing that buzzword a lot as well. And we really feel that the home health industry is really, really well aligned with the broader goals of the healthcare system. So these 3 boxes represent what's called the triple aim. I'm sure you're all familiar. It's about improving the health of populations, improving patient experience, and doing it at a lower cost of care. So it's definitely a lofty set of goals, but we do feel that home health is really well aligned with these goals. This slide is a bit chaotic, but that's sort of the point of it. It's meant to kind of give you a sense of all of the reform that's going on right now, especially in the Medicare program. It seems like every year we get a new bill that, ushers in a ton of new initiatives. And really what this is doing is driving everyone towards this value-based world. So that is really incentivizing those providers that are bearing risk to utilize more home health care, largely because a lot of care can be delivered in a more economic way in the home. So we see this happening, but we also wanted to point out today that there's a lot that the industry really needs to do to be prepared and really capture the opportunity that is being driven by all these policy reforms. Looking out a little bit into the future, we see that there could be really an evolution of the role of Medicare home health. So right now, there's the traditional sort of post-acute care benefits that are deployed. And what we think is going to happen is there's really going to be more movement towards this broader care management role. So really connecting different services and helping with transitions of care. You can see in certain programs now that there are some incentives there to provide additional, in-home visits to try and make sure that people are transitioning in a way that prevents adverse events. So we do see more of a care management role for home health. And then really out into the future, there are lots of innovative demonstrations and things happening where more and more types of services are being provided in the home. Everything from hospital at home, so very acute care being provided in the home, to hospice at home, and all these other models that are really testing kind of the boundaries of what we can do in the home. And that's a good segue into this slide, which is wanting to underscore the point I made about there being a very broad spectrum of home-based care. So while we are generally focused on kind of that middle box right now in terms of Medicare benefits, as well as to some extent hospice on the right, there are really so many different services that can be provided in the home, not to mention long-term care services. This is a really cool graphic that we borrowed, and it again is making that case that the cost of care does go down when you shift towards home environments, and the quality of life tends to go up. But that arrow at the very top is really making that point that is important to remember, which is that the industry has to really develop some more capabilities, some more clinical capabilities, operational capabilities, and expertise to really capture and maintain this shift and this driver towards care in the home. So I said that we talked to some policy and thought leaders, and they had a lot of interesting opinions about the future of home healthcare. There's certainly a lot of variation in what they thought, but some clear themes emerged. Everyone believes that, the reforms, the payment and policy innovations are here to stay. I think we all would agree. And they definitely think that home health is a big winner in that. As I mentioned before, a lot of the focus on value, there's a big cost piece of that. And given that a lot of care can be provided more economically in the home, that's driving risk-bearing providers to really utilize home health. They are the policymakers are providing a lot of additional flexibility to providers who are taking on risks. So that is how we're seeing some innovation happening. But we're still sort of stuck in this fee-for-service context. So that's the challenge that we see. It's kind of the push and pull. They want providers to have some empowerment to deliver care in a way that, basically fulfills the shared goals of high quality and low cost. But we're still operating in a fee-for-service world. So oftentimes there's not enough flexibility there to really deploy the care at the right time for the right people. They also agreed that there should be more flexibility in the way that the home health benefit is deployed. So those of you familiar with sort of the Medicare payment rules, there's the 60-day episode, patients need to be homebound. So there's some very strict criteria for when you can deploy home health. And there was a consensus that potentially that needs to be changed in some way to be able to deploy home health care in a way that makes more sense given the evolution in the healthcare system. Of course, I think they agreed that there may not be a lot of, political will to do some of these things right now. So it may have to flow from providing flexibility sort of further upstream to some of the risk-bearing providers like health systems, ACOs, and sort of letting them provide more flexibilities to the partners they have working downstream. They also mentioned this issue of long-term care. I think that's the 10,000-pound gorilla. That the Part B home health benefit, which is more of a physician-driven benefit, sometimes is thought to substitute for long-term care because we have such a lack of strong publicly financed long-term care system in this country. And that's really where they saw an opportunity to do better, to innovate, and that would obviously involve some policy changes as well as some industry changes. We also talked to some very innovative providers, as I mentioned. We have some high-level findings up here about what they were doing. I don't have time to really go into depth, but these vignettes are posted on the Alliance website, so I definitely encourage you to go check that out. I think basically the themes that emerged from these interviews is really that they are mixing services in different ways that are difficult to handle financially, but that are leading to really great results. So leveraging more clinical expertise, whether it be NPs, physicians, making home calls, also connecting people up with social services, and they're seeing great results. But as you might expect, many of these things are not reimbursed via Medicare, so they have to be funded in different ways. So that was a common theme that we heard. That it's financially challenging, even though they're really showing great potential in what can be done. I'm going to pass it over to Steve now to talk about the characteristics of a home health agency of the future.
Thanks, Sally, and thanks so much for the chance to speak with you all this afternoon. My name's Steve Landers again. By background, I'm a family doctor, geriatrician. Got interested in home care because I kept finding it was the best prescription I ever wrote for my patients, particularly frail elders and their families who were struggling with the basics of life and hoping to stay out of the hospital, suffer less, be as independent as possible. That's why it was an incredible honor when I got to join the visiting nurses and become the CEO of the Visiting Nurse Association Health Group in New Jersey, and that's my current job. I've been on the board of the Alliance for Home Health Quality Innovation since 2012 and currently serve as the vice chair. And so I've got to see this Future of Home Health project from its start to where we are today. And one thing I just wanted to share with all of you that I think is important about this project is that we were inspired actually by the family medicine community. Over a decade ago, the family physicians in the United States initiated a project called the Future of Family Medicine project, where they really looked at what they were doing and how they were set up. Actually, the work that came out of that project became known as a new model for family medicine, which ultimately became synthesized as the patient-centered medical home. So, which the key framing for how we look at primary care in America today was based on this type of exercise, and that's why we thought it was really important as a home health community to also look at how we are positioned and where we should be going. Interestingly, about Sally's comments, just again looking back on going into this, we went in very open with these interviews, with the forums, with the IOM workshop, and one of the possibilities actually in the discussions could have been, it's easy to lose the forest for the trees. One of the things that could have said, people could have said, well, I don't know if this really is an important topic, or this is sort of something from a past era, or really families or computers or doctors' offices are going to do all this stuff in the future. This is really, there really isn't a future. And actually what we saw was quite the opposite. There was an incredible amount of engagement at all the different levels of the project, with payers, with providers, with physicians, with hospitals, what have you, with community members, with caregivers. This is important. This is a key issue for our healthcare system. So really we're talking about the details, but the big picture message was we need a bright future for home health care in this country in order to meet the health system goals on many levels. And that was a really important message that we got out of this. Now, we talked about home-based care in that broad spectrum, and I think that is clearly one of the messages that we heard here, is that there will be an emerging continuum of care at home, acute care models at home, hospital at home concepts, urgent care at home concepts, home-based long-term care, informal care, technology-supported caregiving at home, home-based primary medical care, and independence at home concepts. But we did look at what does that home health agency, that certified home health agency look like in the future, and really have crystallized some key themes about what that home health agency looks like in the future. And some of the characteristics are shared here. Patient-centered, family-centered, focus on individualized goals and care plans. Better connected, not off on an island, less and less independent per se, and more connected through technology connection, where doctors, hospitals, home health agencies exchange patient information more seamlessly. More connected in terms of teamwork and care planning, care plans that cross venues of care from hospital to home, shared protocols, in some instances shared business relationships where various entities in that home-based continuum or in the overall health system are connected through various business integration models, be they preferred provider relationships, network relationships, or true integration or joint ventures. We see that connectivity happening to make it hopefully less wasteful, more efficient, and a better experience for the care recipients, where the care is less fragmented. High quality, and this is really a key feature where evidence-based practices are used to improve outcomes during care transitions in particular, but also best practices in rehabilitation and nursing, and the capacity for data-driven performance improvement, using data and information to continuously improve on quality, and technology-enabled, both in terms of at the point of care, being able to document care and coordinate care using mobile and digital technologies, taking advantage of what the information technology world has brought to us, better use of analytics and data to help us make better decisions about the type of care people can get, and also in between our visits in home care. We know the people we care for often have 168-hour-a-week challenges, those patients, those family caregivers, and we think there will be a role with technology sort of filling the white space in between those encounters, connecting us better, educational resources, messaging, video conferencing, and other monitoring technologies. So, but what specifically, one of the things as a physician, it's, we can write prescriptions. I talked about prescriptions, right? You can write a lot of prescriptions for a lot of stuff. And it's not just, is it good or is it bad? It's sort of when, right? It's some medicines and some things that we order, when it's used appropriately, it's very effective. And when it's used inappropriately, it can be wasteful or harmful. And so one of the things that we looked at in this project is, what is the role? What is the use case? When should the home health agency be activated, if you will, in the care of a Medicare beneficiary? And what we have identified is that for older Americans and disabled Americans in Medicare and in other payer models, that when they have serious chronic illness and some degree of activity limitation, that there are certain points in their care, in their time, where activating the home health agency is likely to make a big difference, and also make a difference in meeting Medicare's triple aim of a better care experience, better population health, and lower costs. So one of those scenarios is in partnership with primary care, both office-based medical homes and home-based primary care concepts, or home visiting primary care concepts. Those primary medical care teams, physicians, advanced practice nurses, will encounter scenarios or times in the care of their patient when things aren't going well, when they're having an exacerbation of a chronic condition, when there's been a fall, when there's been a decline in function, when there has been a new risk or a new type of medicine or equipment that requires extra nursing rehabilitation support. We envision the home health agency being that local hub and resource that can come in and provide episodic support to buttress, to enable that ongoing primary care in the community, to meet the goals of those primary care programs of high quality care, lower longitudinal costs, lower hospitalization, institutionalization. In the context of acute care, hospital care, or acute care at home, when somebody more and more has an acute care episode, but it's able to be managed in the community, the home health agency, again, can be activated in partnership, collaboration with hospitals, with other folks that are taking risk in trying to convene more care at home. And in those acute care moments when things aren't going well and there's a need for days or maybe several weeks of additional surveillance, monitoring, assessment, education, interventions, infusion, wound care, what have you, that the home health agency would be activated in those contexts to enable care at home as opposed to post-acute care in a facility, or acute care at home as opposed to acute care in a facility. And then the other scenario, a bit overlapping with the primary care, is enabling long-term care at home. More and more older Americans hope to be able to age in place at home in spite of needing help with the basics of life. And they will be often getting support from their families, informal caregiving as a way of getting long-term care at home. They may be part of Medicaid waiver programs and other community-based long-term care programs in their states, or they may be privately hiring long-term care services and supports in order to help them at home. But invariably, in those social support models, there will be days where their ability to remain at home and cared for in those models will be threatened by declines in their health, by exacerbations in chronic conditions, by geriatric syndromes like dementia and falls and others. And those are scenarios where home health agencies will again be able to partner with the long-term care providers and the long-term care leaders to escalate care at home, to stabilize situations, and to keep people at home instead of in hospitals and facilities unnecessarily. So that's really where we envision the future of the Medicare Home Health Agency, working in this new continuum that's emerging at home, and with the changing providers that have already existed to try and drive more people being able to age in place, stay home, avoid unnecessary hospitalization, and have a higher quality of life. And I think we get to toggle back to Sally.
Thank you so much, Steve. So in order to fulfill this future, I think we want to acknowledge that there are some capabilities that home health agencies are really going to have to build up. And this diagram shows a couple of those, probably most of those. If you look at the three shapes on the left side, those are really about broadening the types of services that can be provided. So to be able to be deployed in all of those circumstances that Steve spoke to be able to have different roles in the care and provide everything from primary to acute care. That is not to say that every agency has to do all of those things, but as an industry, there needs to be those capabilities in place. There's also some boxes here for the tech-related capabilities, HIT, and remote monitoring. So it's key that agencies are able to really be interoperable. So you can't really serve in that care management, care coordinator role if you're not able to speak to the other providers, invested in the care. So that's very critical. As well as, to your point, engaging the family members, providing education to them. Maybe there's an app for that. Maybe there's a way to really, share information in a way that supports the care plan that home health agencies can really be a part of. And then the care transition support. We keep discussing this. It's really key to be able to do that. And sometimes this support can go beyond the typical sort of deployment of the benefit of the post-acute care services into some other, types of communications and types of education, things like that, that will support that care transition from a certain setting of care back to the home. So there are a number of challenges. We certainly wouldn't want to suggest that this will be easy. There are a number of barriers that exist to really achieving this future and this vision. There's some financing and regulatory issues that we discussed that really make it difficult to deploy the benefit in the way that makes the most sense. So that's something that we think there can be some improvement in. Addressing program integrity and fraud and abuse. This is clearly a stigma that's attached to some of the home health industry that really needs to be addressed in order to be really taken seriously for having really the potential that's there. And measuring performance. We need consistency in how quality is defined. So many of these new models are focused on quality and cost, but often there isn't a good sense of what quality means, and it doesn't translate amongst different settings of care. So what's quality in a nursing home may not be quality in a home health setting or in a hospital. So there needs to be more consistency there. There's workforce limitations. I think throughout healthcare we see that maintaining an engaged workforce is a challenge. So that obviously applies to the home health industry as well. Clinical capabilities related to diseases focused on by APM. So, for example, the CJR model, the joint replacement bundle, there are certain conditions that are really being focused on. So home health agencies should kind of take a cue from that and make sure that they can provide some targeted services around those key conditions to really serve in that partnership role with the provider that's assuming risk for those patients. Operational capabilities, we've talked a little bit about this. That has a lot to do with, that tech enablement that's there, but also developing relationships with entities that they haven't really had to develop with before, whether that be ACOs, health systems, other types of payers, to really be able to have that integration in the way care is deployed. And then finally, long-term care. Again, we could probably spend a whole another briefing on this, but that is a barrier to really being able to fully manage a patient in the home if there is no financing mechanism or way to address those, functional limitation, other issues like that. I always like the story of the woman who continuously gets readmitted to the hospital for gastro issues, and no one really knows what is causing them. But the hospital treats her, sends her back home. She keeps getting back. And all it is that her food is spoiled. She's just not eating fresh food because she's not really able to get to the grocery store regularly. And all it would have taken is a social worker or maybe a home health aide or someone to just evaluate the living conditions that she's in that would have prevented many, many, many hospitalizations and a lot of costs to the healthcare system. So that is, a big issue to address, something that, the home health industry can't do alone, but certainly could play a huge part in shoring up some of those issues that we see. So in conclusion, I think the key message is that we think that there's some meeting in the middle, if you will, that should happen. So policymakers should think about ways that they can provide some flexibility in the way that the home health benefit can be deployed, especially in these alternative payment models. Perhaps it is providing some flexibility to the home health provider. If not that, maybe it's providing some flexibility to the risk-bearing entity, so the ACO or the hospitals in CJR program, for example, letting them utilize home health services in different ways. That's something that we think would really, really help. But it's also up to the industry to really capture the opportunity that's there to have those capabilities to fulfill the future that Steve talked about. So it's really, it needs both pieces really have to come together to capture this vision for the future of home health care. So I will turn it over to Teresa for the moderated discussion now.
Great, thank you all. And I wanted to ask a question, and I think this is particularly directed towards Kathleen and Steve. So in our project, we did profile some innovations, and I'm interested in what kinds of innovations in healthcare delivery you're seeing that are making good use of both home health and home-based care.
Well, I'll jump in first, and I think the thing that people think, oh, technology must be the answer. It's not the silver bullet that we think it could be, but I think what we are seeing, and I can speak for the network of Interim Healthcare, is there are opportunities where there is simplified technology. There's both platform technology for conducting the business, the actual scheduling, the applicant flow, the managing of where the care is being delivered. So think about it as kind of like the airline reservation system. They all operate on one platform, no matter what airline you're going to fly on. The healthcare world does not have that. Hospitals don't have it, skilled facilities, and certainly home health doesn't have it. So you've got a lot of different choices to make that are probably more made based on cost and the fit for the business that you do. So that part is getting better because I think there's just more technology companies who are focusing on the post-acute. So that's a good thing. On the side where we talked before about the challenge of workforce and then also the patient satisfaction, the technologies that we're seeing are simple device technologies, non-intrusive technologies that can really be, when you said, is there an app for that? It's really application driven, whether they are telemonitoring for very simple reminder, almost a social model of making sure that there's the activities of daily living, like did you get your shower today? Is there the schedule for the doctor's appointment, and is there transportation that's needed? Some of it is getting a little more sophisticated where it's actually the biometrics. So where I believe that really could be helpful, and what we're looking at is how do we actually bring that more to the level of the certified agency, is so that you can actually augment, or in some cases you may be able to manage the workforce that you have better, so that the highest cost is having an actual caregiver go to someone's home. If it's to perform a skilled task, if it's to really perform a plan of treatment, that's what it's designed for. But when you have uncertainty or there's a vagueness about a patient's symptoms, the biometric trending and tracking really does help deploy when does someone really need to see the nurse or someone needs to have that aid. So we're finding there's more availability of that, largely in startup companies. This isn't a broad-based Apple swatch that you can give out to your patients. But the other piece of that is there is no reimbursement for that. So agencies are making a choice to take and reinvest by using that, but it is simply going to have to be at a measured pace. It's not something that can just be an automatic. So it's a planned budget, it's a capital expense. So I think those areas of technology about how to operate the business more efficiently and produce better data, and then what is really that patient-centered but yet consumer-friendly. I don't think this technology about, nanny cams and granny cams and, everybody's being monitored, that may be going a little too far, and what we find is patients don't like that. But things like, fall protection, door alarms, those are becoming a little bit, more available. Sometimes families will say that's something they'll cover, but I think that we're still going to be in a world where there's not necessarily enough broader thinking about what actually helps implement the best care and get the best outcome.
I think Kathleen touched on a lot of the technology innovation. I think there's a few innovative things happening. Some of them are dusting off of old concepts that are really relevant. One being home-based primary medical care. For example, the return of the medical home visit. In those programs, what we're seeing is that they're able to help people stay home through working closely with home health agencies and hospice care. So it's a great, if you will, what's an innovative way of using home health. It's as a partner in the context of home-based primary care, and whether it's the VA home-based primary care model or the Independence at Home demo sites or some of the university sites, we've seen that people have been able to get better outcomes at a lower cost through that type of arrangement. So I think that's something important to make note of. Another, again, not particularly innovative, but it's certainly being used by people that are trying to be leaders in quality and value, is the getting more people home as their first post-acute destination after things like orthopedic surgery. I know that's been a big push with the CJR initiative, but I know with my colleagues that I worked with at Cleveland Clinic, going back 10 years now, they had worked over time at getting, well over 75% of their knee replacement patients going straight home after joint replacement surgery as a way to improve caregiver patient experience, value, and so we got a lot of opportunity there to just get people home as their first post-hospital destination when possible. And then there's a lot of, innovation, if you will, going on in the area of partnerships. And I think that more and more people are recognizing that to meet the goals of new payment models, to meet the goals of the Medicare program, and serve our communities well, this is a team sport. We can't all be a bunch of one-man bands. We've got to play more like an orchestra. And so we're seeing throughout the country innovative new relationships between different home health organizations and hospital, physician, long-term care entities. In my organization, VNA Health Group in New Jersey, virtually all of our home health services are done in joint venture partnerships with hospitals and health systems. We've seen a whole range of network relationships, preferred provider relationships, getting at that team and connectedness issue.
Thank you both so much. So Sally touched upon this, and so did Steve, just a little, sort of the multiple alternative payment models that are being tested by the Medicare program, many that involve risk sharing. My question is, how can home health agencies be strong partners in those risk sharing models? What do you see in the future, and how should that look?
Well, how to get there, I think a lot of the risk-bearing providers are really not yet focused on post-acute care. So they're getting there. But I think they're starting with sort of their own operations and sort of those really, really high-cost patients. And so what we're seeing is that post-acute care providers in general have to make a really strong case. And so a lot of that's about evidence. So it's about using data to really show the value that you provide. I think it's not always clear to them that allowing for that post-acute care cost up front is actually going to save costs down the road, so that if you use home health, for example, the person is less likely to be readmitted. So if the home health provider has good data to show that, I think that's what's resonating really well, rather than just saying, please work with me. The data is really, really, really helpful to actually get those partnerships in place. And then once you have them in place, it doesn't stop, that you need to keep sharing data, sharing resources. We've definitely seen some innovative partnerships where there's a data sharing on both sides, and the post-acute care providers are also sometimes able to share clinical resources that the hospital or the health system or the physician group has. And so there's really, it works best, I think, when there's a real partnership there, when it's not just a preferred provider network. It's not just, okay, we'll try to send patients to you. It really needs to be kind of a two-way relationship.
I guess my comment would be is I appreciate that, Sally, and I think that that is kind of the vision forward. But I also think we have to stay very practical. We live in the world today, and those who have taken on the risk are either physician groups or ACOs or conveners. And by and large, they have not given any, lip service maybe only to taking risk. It's been negotiated fee for service, and the lower the better. So I think that home health agencies are sort of in that, catch-22 of, in order to even have an appetite to take risk, which I think, if you look at, if they feel confident in their quality, they're doing their stars, they're collecting the data, they've got standardized clinical practice, but they're dealing with putting on their helmet and seatbelt every day, to manage their referrals and scheduling. Part of being able to even have partnerships that would allow home health to say, I'm comfortable to say we now have worked together enough that we would want to take risk, would almost have to be a phase that it would go through. Because if you started fee for service and deliver the results and the outcomes, then really give you the evidence to say, if in a defined area with rails, guardrails, I think is kind of the way I refer to it, of how much risk you're willing to take on. Most home health agencies today in the U.S. at the size they're at don't have a huge ability to take on a lot of the risk. If they can deliver under the model of reimbursement, it's really not sustainable with regs in cuts every single year. So I think we're ahead of ourselves, to be honest, from kind of a practical standpoint. It's a great goal to have, and I think as we look out to the future, home health has come of age. It should be getting an equal seat, and we probably, truthfully, I hope we see the evidence that disproportionately we impact having better outcomes for patients because there's been an intervention of home health.
I absolutely agree. I think, to be more clear, I think what I was talking about is more about this notion of just sort of getting into the partnership, getting into the network. We are not seeing a lot of risk sharing downstream, and that's what makes it hard, I think, for the industry to want to innovate, because they're not really able to kind of share in savings and things like that would give them that incentive to really, build those capabilities. So, the hospitals and the risk bearers are saying, oh, join our network and, you can get more volume, which is good for you financially. But they're not really sharing, not just risk, but the savings opportunities that would really provide the financial ability to be able to, build those capabilities. So I definitely agree with that.
I think we're in agreement there. The market share is really what the risk organizations are holding out as why you would want to work with them.
I think with respect to risk, Teresa, what's really going on right now in traditional Medicare are a range of initiatives that add incremental risk from the fee-for-service system, but it's not really typically anything that related to a full risk model. So we're seeing, with the ACOs and the bundles, a bit of retrospective reconciliation of fee-for-service payments against a benchmark, and then some penalty or reward based on performance, with value-based purchasing, based on outcomes, to what extent your payment is adjusted or tweaked. So I think that in that context, in each market, each organization is at a different phase in their maturity and their resourcing of being good in those models. I think we're just going to see that continue to mature, assuming the policy stays the same. I think within really all of those different arrangements, home health has a lot to offer as a key partner, as a utility, as a resource, and can and should be able to negotiate relationships that help them get more reward if in fact they're part of the value creation, and in some cases take some of the risk of outcomes when they go poorly. I think those opportunities are there. I would say that there's two dynamics going on, and if you look at them you can almost, it's almost one of these, if you're not confused, you're not paying attention. It's, on one hand, we have this march towards alternative payment models and the incentive for the delivery system to help more people succeed in the community rather than using unnecessary hospital and institutional stay. And on the other hand, we have the protectors and the defenders of the integrity of the fee-for-service payment model in the way that it existed in the past. And sometimes, in order for home health to really make its biggest potential impact in this future model, we need to adjust some of these policies and initiatives that really get in the way. So currently, the paradigm of oversight of home health has been to successively layer more and more administrative and regulatory paperwork on physicians and practitioners that engage with home health agencies. Well, in new payment models, the goal is to be focused on helping people meet their patient-centered goals in the low-cost venue to problem solve, not to spend time with administrative paperwork exchange. In this other paradigm, there is a very narrow, although poorly understood, homebound criteria. In the new payment, alternative payment model, value-based model, the goal is if the person's high risk and providing home health intervention is going to lower their risk of future spending or future suffering, you want to be able to activate that resource to help them. But they may not fit perfectly into that traditional homebound criteria. So we've got some work to do with respect to aligning the regulatory and oversight model with the goals for the future. And this is not an impenetrable or unachievable goal. It's just a challenge. It's one of the things that's going to continue to get in the way, and we've got work to do. Some of it would, could be done with some, leadership focused on optimizing the role of home health, and that's what we're trying to advance.
Great. So this is my last question before we go to our Q&As from the audience, both here in the room and on the internet. How should the framework for the future of home health care inform policymaker and industry efforts to achieve the triple aim?
I'll take first shot. I think as we look at that triple aim, it's a very aggressive goal. It's noble. It's well intentioned, and I think we can get there. I think we're on the evolutionary road. But to me, the population health seems to be what makes a lot of sense in managing whole populations of patients. And if we look at that, the number one thing that pops up with the populations is med reconciliation. And I think, bar none, in my history in the home health industry, home health agencies do a far better complete job of knowing and reconciling medications that are in the home than anyone else. And I think it's because of the intimacy of the environment. It's the transparency of what people will do and tell you and show you in a home compared to what they will take out of their purse or drawer in a doctor's office or in a hospital. So you really kind of get the aha moment when you know how important med reconciliation is, because it's the leading cause of rehospitalization. It leads to all the other complications of falls and inappropriate use of even the resources that are provided. So I think if in my mind that triple aim really would be well suited in home health. So as policy makers, as stakeholders, is there a mechanism that we can begin to see how would we apply that as we move from today, just individual referral to where there are bigger populations that we manage. I think that is something we could do exceedingly well in the certified agencies.
Yeah, I would agree with that. I think the key is just to provide more flexibility, to your point, Steve, about being able to activate the benefit. And it may not be about redrawing the fee-for-service benefit in an exact different way, because then again, you still may have this issue of the criteria and sort of the burden of proof and things like that. What we want to do, I think, is policymakers should think about how to give more flexibility to the providers that are bearing risk. There's been a lot of focus on fraud and abuse, and I wouldn't say that's wrong, but I think if you allow the risk-bearing provider more flexibility to deploy the home health benefit, they are not going to let the home health provider just go buck wild with it. They're going to have their own controls there. So if you are going to push all this risk down to providers and other entities, I think you need to give them the flexibility to kind of self-regulate a little bit more than it is today. To everyone's point about, we're still sort of in this fee-for-service context. So it says, they're saying basically, here are the goals, do this, but you still have to operate in the old system. You can't actually be innovative in the way that you meet those goals. And I think that's where we would like to see some changes and really adding to some flexibility there.
Yeah, I think, policymakers, I guess, to me, they got a couple big issues. One is they've got to be stewards of our scarce public dollars, our scarce public resources. So, money is a big issue from a policymaker standpoint. And then they also have to, make sure that that the quality of life in the society is strong. And so, it's sort of those two things, money, people, money, votes are what are important. And home health, it's a really national treasure. Our network, our home health infrastructure is it's a special resource that is not fully optimized. It's not fully utilized, recognized. It can be leveraged to address both. That's why I love it so much. You can both work to lower costs. If we get somebody straight home from the hospital after surgery, that first 30 days of post-acute care in a home health setting is going to be about $1,300 versus closer to $13,000 in a facility-based post-acute setting over that time period. So we can get people home. We can lower costs. We can address their needs and their families' needs. And this is a big quality of life issue. It's a big humanism and compassion issue that we help people remain independent, autonomous, and with support in the community. So, I think this is a core resource that needs to be looked at as something to invest in, something to optimize, something to love, something to build on, something to make sure the problems are fixed and the things that aren't working well are addressed. But overall, if we're going to be successful as a country with 70+ million baby boomers and helping them age in place and not having Medicare become the whole gross domestic product, we're going to help people at home, and this is a big deal, and we can partner.
Thank you. I'm going to open it up to questions here in the room, and if there are any questions on the internet, I'll look to my staff back there to pass me any questions that you have. Anyone with a question in the room? Please make sure you announce your name and your affiliation.
I'm Mary Narayan, and I'm a home health nurse. And currently, I'm a doctoral student at George Mason University, and I'm looking at the future of home health nursing. Okay, and so first off, I want to thank you for the work you've done and the visioning. And I am wondering if there is a place. Could there be a place, should there be a place for home health nurses to have some sort of formalized mechanism for being part of strategizing for the future of home health care?
Well, I'll take the first shot at that because I am involved in the State Nurses Association and even the American Nurses Association. They are beginning to realize that nurses can shape and give proposals and offer solutions that oftentimes can actually impact the delivery of care and even have an influence on the policymakers. So, Mary, I'd love to get your card and let's talk about it, because as a doctoral student, I applaud that. That is, a huge step in your career, but it also says that you are going to be focused on what the future is, because that is where our big crisis is going to come. So we have to start getting this calibrated better. And nurses have been the backbone of the skilled care delivered. And if any of you have seen, I just recently saw that movie Back to the Future. I feel like that's where we're going, because as Steve said, we had physicians at home, you had public health nurses, so there was already the roots of that in our system in the country. And now we've really just we've kind of had to go up the escalator to be getting to the point where we can handle the greater demand, the demographics, but also the skill has changed in the delivery model. So I mean, I see someone nodding, and it's not the same nursing care that 10 or 20 years ago was delivered at home. It's way beyond that.
Yeah, and the nursing perspective is essential. And then actually, within the work that we're sharing with the Future of Home Health Project, nurse leaders and representatives,
Yes,
their
they've been involved.
input was among the most important feedback and information that was brought into the project.
Okay.
Is it on? Okay, thank you. So my name is Esther Ejim. I work with Niger Worldwide Charities. It's a US-based charitable organization, but our job is worldwide. I came in late, so pardon me if I'm taking you backwards, but I just listened to the last few minutes of this conversation, and I'm wondering, how about the caregivers themselves? And I'm not talking of the nurses, I'm talking of the home health aides who do this job. I mean, they do the bulk of the jobs. They are the ones who take care of these patients, but they get the least, the most minimum payment. And for most of them, when they go to do this job in the home, they don't just take care of the patients. They take care of everybody in the house. They become the housekeeper. They become the caregiver and everything else in between, the driver. But nobody cares about that. What we hear is abuse here, abuse there. But what about them? Who takes care of their own interest?
It's an important point. I've, as a physician, been regularly humbled by how home health aides often, if not more often than not, have a bigger impact on human health and well-being among frail elders than physicians do. And the work is just incredible. I'll put a plug in. I wrote a blog about home health aides as the hidden angels of our health system on HuffPost, and offered some solutions. But there's a major need for us as a country to focus on how do we elevate the role of home health aides? How do we support them in their career development? How do we have sensible regulations so that people can come out of the shadows and work in legitimate employment arrangements as well? There's big issues on the private pay and hire side with home health aides. A lot of issues that you bring up, and thanks for raising that. It's a crucial national issue.
Yeah, the only thing I want to add is that if you look in your folders, we have some designed materials about the 3 roles of home health care in the healthcare system, and caregiving is always a critical piece. If you look, I think of it as sort of a trifecta between, skilled nursing and therapy, caregiving, and primary care in every instance, and we do not operate in a silo. So, thank you for all of the work you do on behalf of caregivers. I think maybe one more question, and then we're going to have to wrap up.
Okay, I'm Maureen Daly from the American Nurses Association. Full disclosure, I have 30 years home health experience. But I'd like to build upon and comment on the importance of data and demonstrating the value for home care, both organizational attributes, structures of care. What's the HIT? What is the workforce? The right mix on the interprofessional team with the right staffing and experience and training, education, as well as structures for populations at risk, population health that yield the best outcomes. And there's a nursing science big data group. They had their meeting this past month, and they're working on getting standardization of nursing data across the continuum of care into the big data warehouses where this predictive risk modeling is going on. So that's really important, to partner across the continuum of care to get standardized nursing languages, because we know that assessments of patients for risk and prevention, a lot of that is done by the nurses across the continuum of care.
Absolutely.
Thank you.
Thank
Great. Thank you. I want to remind everybody, just before we wrap up, all of the materials from today's briefing can be found open to the public on the Alliance's website. So I encourage you to check it out. Again, I want to thank all of you for participating today, and we'll hope to stay in touch with all of you as we get to publication of the report's final paper. And I want to thank our speakers here in the room. Please join me in thanking them with a round of applause.
Thank you.